We discussed polio when we discussed spinal cord lesions. You should remember that this is caused by poliovirus. This virus is transmitted by what route? It is transmitted by the fecal-oral route. I just have a lot of thoughts when I hear fecal-oral, and none of them are good, and I'm not going to share any of them. However, this is pretty common in areas where there can be issues with sanitation. You can get fecal-oral transmission of many different types of viruses and bacteria. Once it's transmitted, it then replicates in the digestive system before entering the bloodstream. There it travels to the CNS where it damages the lower motor neurons in the spinal cord. Symptoms include weakness, hypotonia, and paralysis. Over time, you can also see muscular atrophy, and this is what you see here in this photo. Spinal muscular atrophy can manifest in a number of different ways. The most severe form, as we discussed earlier, is Werdnig-Hoffmann, which occurs in the first months of life. It is also sometimes referred to as floppy baby syndrome. So what do you think is the main cause of death? Well, death usually occurs due to respiratory system failure. This is because the lower motor neurons that control the diaphragm are damaged and no longer work. Here we have a depiction of a child with Friedreich ataxia. There are a few things that you might notice. You can see kyphoscoliosis here. You might also notice hammer toe. Now, neither of these things are specific to Friedreich ataxia, but combined in a child in the right clinical context, Friedreich ataxia should be on your differential. It is caused by a trinucleotide repeat GAA in the gene encoding frataxin. Now, we've mentioned this before. So, what is a common genetic pathophysiological mechanism that happens in trinucleotide repeat disorders? This is anticipation, where the number of repeats increase, leading to increased symptoms during earlier years for each generation. I mentioned this when we went over Huntington's disease, which is a classic manifestation of this effect. Cardinal symptoms of Friedreich ataxia include progressive limb and gait ataxia, dysarthria, loss of joint position and vibration sense, and hyporeflexia. So what do these patients most commonly die of? Well, the gene mutation also causes a hypertrophic cardiomyopathy, and this is actually the most common cause of death in these patients. Now, as I mentioned above, they may have other bony deformities like pes cavus in the foot or kyphoscoliosis that present early in childhood. Okay, we have reached to another flash quiz. What are Argall-Robertson pupils? You should remember this. This is a dysfunction in pupil reflexes seen in tertiary syphilis. The pupils will constrict when the patient focuses on a near object but will not constrict in response to light. And remember, we said that these are pupils that accommodate but don't react. Prostitutes' pupils. This actually works really well, right? Because we're talking about syphilis, you have prostitutes, accommodation, reaction. I don't know, it kind of just fits together nicely. The final spinal cord lesion we'll discuss is Brown-Sequard syndrome. This is a fancy name for a lesion that disrupts one half of the spinal cord. It was first discovered by Charles Edward Brown-Sequard, who saw it in his patients, and he made these drawings. So as you can see, there's damage to half of the spinal cord in these drawings. All three columns are damaged, so this is almost never seen clinically, but when it is usually the result of trauma such as a stab or a gunshot wound. So, let's deal with each of these tracts and how they are affected. Let's say that we are going to shoot this person, and the bullet is going to enter there. And it's going to go, of course, like all the way through, and we're going to injure the spinal cord. Okay. For the corticospinal tract, damage will cause what type of deficit? Well, we should see ipsilateral paralysis or motor weakness. At the site of the lesion, there will be evidence of lower motor neuron damage, such as hyporeflexia. However, below the lesion, there will be signs of upper motor neuron damage, such as spasticity. Since the dorsal column should also be injured, what type of deficit will the patient have? She should have impaired ipsilateral vibration and position sense. And lastly, we know the spinothalamic tract is damaged, and this will give us impaired contralateral pain and temperature sensation. However, that will be below the lesion. At the site of the lesion, loss of pain and temperature sensation will occur ipsilaterally. Thus, at the site of the lesion, the patient will end up losing all of sensation, and below the site of the lesion, there will be a mixed bag of deficits. Now we'll discuss some very important dermatomes. A dermatome is an area of skin supplied by a single nerve. Usually when we say dermatome, we are referring to the sensory dermatome. This illustration gives you the general landscape of the region of each dermatome and its corresponding cervical region. However, we will only focus here on the most high-yield dermatomes. The highest yield dermatomes for you to know are C2, this is the distribution for the back of the head. You should know T4, which is at the nipple on most bodies. T10, which is at the umbilicus, and then S2, 3, and 4, which is the distribution of the genitourinary zones. Now the rest of them could be tested, of course, so they're worth knowing about, but really these are the main ones that you should be interested in. And there are a few nice mnemonics in your book that will help you with the memorization. Now there's a highly tested infection that involves a dermatomal rash. What is it? It is an infection with varicella-zoster virus, or VZV. This virus causes chickenpox after an acute infection. Once chickenpox has subsided, the virus remains latent in the nerve roots and can become reactivated in response to immune suppression. And that can be caused by a variety of things, including stress. This reactivation leads to shingles, which is what is seen here. You can see that the rash is in a very localized region that coincides with the dermatome of the infected nerve. Now, to complete the integration, what type of virus is VZV? It is a herpes virus. Now we'll mention clinical reflexes, and we will use this soccer legend and ex-player for one of the greatest clubs, Chelsea Football Club, as a model for where the reflexes are as well as the spinal nerve that governs those reflexes. You get extra credit actually if you know his name. It's very high yield for step 1. So, the bicep reflex tests the C5, C6 nerve root, while the tricep reflex tests the C7 nerve root. The patella tests L4, while the Achilles tests S1. You'll notice the pattern that as you move from joint to joint, you are essentially counting up from 1 to 8. This is a good way to remember the corresponding spinal nerve for each reflex. In the clinic, it is useful to say how strong a patient's reflexes are, as it might give you some information about a certain pathology. This scale goes from 0 to 4+, with 4 being hyperactive. When you say someone has normal reflexes, you mean it is a 2+ on both sides. Lastly, when speaking of reflexes, I couldn't go without mentioning the Babinski reflex. Do you know what a positive Babinski sign is and what it indicates? Because you should. A Babinski reflex is an upgoing big toe when a blunt instrument is run along the bottom of the foot from heel to toe. In adults, this is a sign of an upper motor neuron lesion. Now there's one more thing I want to cover, and that is the extra credit question. This legend's name is Didier Drogba, and this picture speaks for itself. Okay, moving on. It is time for a flash quiz. What is the classic triad of symptoms for Horner syndrome? Again, this is a classic triad you should definitely know. Ptosis, anhidrosis, and meiosis. Primitive reflexes are those reflexes that we are born with but disappear in infancy. These are tested in newborns to help rule out brain damage. The moral reflex is what occurs when the baby thinks that he is being dropped. The baby will extend its limbs as if to grab onto something. This is normal up until about 3 to 4 months. By the way, if you have kids that are babies, feel free to practice these reflexes on them. Next, we have the sucking and rooting reflexes. This is an illustration of a rooting reflex. Babies intrinsically know how to suck something if it is inserted into their mouth. The rooting refers to the baby turning to one side if the cheek or mouth is stroked, trying to search for food. This reflex lasts until about 2 to 4 months of age. We also have palmar and plantar reflexes. This illustration represents a palmar reflex. When stroking the baby's hand, they will grasp your fingers tightly and can even sometimes pull themselves up. This disappears around 6 months of age. As you know, the Babinski reflex is an upgoing big toe with plantar stimulation. However, unlike in adults, it's actually normal in babies until about 1 year old. The Gallant reflex is less commonly tested. It involves lateral flexion of the lower body toward the side of the spine that you are stroking. Again, feel free to enjoy these when you have your child. There's some good videos on YouTube that show examples of these reflexes. You should definitely check them out.